Good afternoon, and it's such a pleasure to be here with you all. Gosh, I really wish it were in person and we all could be enjoying a meal together, but it certainly is a good time to be talking about plant-based nutrition over lunch. And we're going to talk about specifically how plant-based nutrition can benefit our cardiovascular patients and us in general. So just my only disclosure is that I am a part owner of a culinary medicine practice. And over the next 40 minutes, we're going to first talk about lunch and the lunch that you all may have prepared in advance of this. I know that you were sent a couple of recipes, so some of you may have chosen to make some of those, so we're going to review that first. Then we're going to talk about some dietary patterns, some data on diet and cardiovascular diseases, as well as specific foods that impact the cardiovascular system. And finally, we'll end with some interventions specific to some of the patients that I've seen in my practice. What we're not going to talk about today are specific biomarkers associated with diet, specific diets in general, but what we will focus on is evidence-based dietary patterns and specific interventions that you can make in your own practice and in your day-to-day life. So this is my lunch today. I have it. I'm going to enjoy it after the talk, however. But this is really what culinary medicine is all about. I'm going to tell you a little bit more later in the talk what that means, culinary medicine. But basically, we teach our patients how to use medications. We teach them how to inject Lovenox, how to use insulin. How can we expect them to know how to use our prescriptions if we don't teach them how to do it? And so we're going to be talking today about a prescription of food for our patients. And what you'll learn is that it's not just about telling patients what to eat, but it's also telling people how to eat. And so we've given you an example of that in today's lunch. We said we would be doing this over lunch. I would have in advance asked you to prepare a healthy plant-based lunch, but you may not have understood what that meant or how to incorporate a plant-based lunch into your daily routine. And so here's one way that I prep my lunches. It's been particularly helpful during this time when there aren't places to get carry out. One of my personal favorites, Sweet Green, is tough to get these days, although they do order carry out. So what you see here is my meal prep, and this is something very simple that you can do once a week in planning out your lunches. And it doesn't really, the ingredients there aren't as important as the different components. So you can see that I have some whole grains in the back. I chose to use farro, and next to that you see some garbanzo beans. There's a dressing that I made. It took about all of 3 minutes to make. Nuts and seeds that you can see here, and then any kind of vegetables you want can mix into that. And then you assemble it all in a jar with the dressing at the bottom, and then you stack it up, and this can stay in your refrigerator for 4 days. So you have lunch for 4 days now in advance. Great to use with leftovers. So now on to the main program. I have to say, though, that slide that I just showed you is perhaps the most important lesson of the day, because I really want you to be able to take that back to your own practice and teach your patients how to do something similar, because there is a public health crisis. And no, we're not talking about COVID-19. We're talking about food. And actually, that has translated into our current crisis, because we know that obesity is a very strong risk factor for people having more severe disease when they do contract COVID. So food is the number one cause of poor health in the US and worldwide. This is typical of what we see in the standard American diet, right? We have snacks that are consisting of packaged foods, essentially. I mean, there's nothing on here that is necessarily identifiable in terms of a single ingredient. In fact, I would challenge you to look at anything on that screen right now and pick out a whole food ingredient. Actually, no, I would say I think I see a tomato in there, but that's actually a piece of a hot dog. So anyway, no whole foods in that photo there, and that's typical of what we see in today's standard American diet. Now, this is a slide showing the data from the state of the U.S. health burden of diseases that was published in JAMA in 2018. This is the most recent data that we have. And what it shows is that suboptimal diet is the #1 risk factor for premature death from chronic disease, and specifically cardiovascular disease. And what you're seeing on that very top bar is that, again, dietary risk goes above tobacco use, high blood pressure, body mass index, plasma glucose, cholesterol, et cetera, et cetera. And in that top bar, you see the various colors there that lead to suboptimal diet, disease associated with suboptimal diet. And the blue line represents cardiovascular disease. You can see that in the right-hand column here, the various communicable, maternal, neonatal, and nutritional diseases and non-communicable diseases. This is all based on non-communicable diseases. Cardiovascular diseases takes the bulk of that bar there. So when it comes to food and health, poor diet is the leading cause of death and disability, with 700,000 deaths per year. And it's associated with many chronic diseases, obesity, diabetes, cardiovascular diseases, and certain cancers. And nearly 50% of deaths related to cardiovascular disease, stroke, and diabetes can be attributable to a poor diet. And in fact, it's estimated that with improved eating behaviors, 1 in 5 premature deaths can be prevented. But how many physicians discuss diet during routine office visits? Think about it yourself. When you are going through your checklist and your, shortened time allotment that you have with your patients, do you have the time to have that discussion? Do you even think about it? I know I personally never thought about thinking about diet as a prescription when I saw my patients until I learned a little bit more about the impact of diet on cardiovascular disease. We are trusted sources. So when we as physicians talk to our patients about diet, 70% of patients will report that they made a change in their eating habits based on that direct conversation that their physician had with them. This is a survey from 2018 where they surveyed 1,009 Americans aged 18 to 69 and asked that question. If your doctor asked you to make a change, would you do it? So food can be a powerful medical tool. It is the great equalizer. We all have to eat. And our choices directly determine how we feel, how long we live, and really how we die. And when it comes to cardiovascular disease, it's not just about fat and cholesterol. That's what I learned, in residency and medical school. It's all about the fat and the cholesterol, and tell your patients to eat a low-fat, low-cholesterol diet, and they'll have tremendous health benefits. And as it turns out, what we don't eat may be a more powerful predictor of health or disease than what we do eat. And it's not just about fat and cholesterol, and we'll dive a little bit into that. Here are some data from the Global Burden of Disease study that was published in Lancet just last year. And this parses out the individual contributors to various components of the diet that are attributable to dietary risk factors. So you can see at the very top, the diet high in sodium really is the front runner there in all diseases. But in cardiovascular diseases, you can see that it turns out that a diet in low in whole grains actually takes the front runner there. But diets low in fruits, nuts, seeds, vegetables, low in seafood and fiber, low in polyunsaturated fatty acids, low in legumes, diets high in trans fats, low in calcium, diets high in sugar sweetened beverages, low in milk, high in processed meat, and high in red meat. But it's surprising here, when you look at all of the media and social media and all the things that are touted to be unhealthy for you, no one talks about you have to get more whole grains or you've got to get in your fruits and veggies. It's really focused on some of these things that are impactful but lower on the list here. So I want to really draw your attention to those things that are on the top of the bar there. This is a study in JAMA that was published by our colleagues at the Harvard School of Public Health. And again, sort of parsing out the individual components of a diet and how they are contributing to disease risk. And this actually stratifies out men versus women, and men seem to be a bit more affected by dietary factors when you look at the darker bars compared to the lighter bars. And as it turns out, there have been other studies that show when we make changes in our diet and we improve our intake of plant-based foods, that has a higher beneficial effect than it does to men than when men make those similar changes. But again, you see here that diet high in sodium, low in nuts and seeds, low in whole grains, low in fruits and vegetables, those are all the things that are attributable to increased risk of death from cardiovascular disease. So we're going to just take a moment, and I'm going to do a little quiz. So I want you to just think about this, and we'll go through it again. This is culinary medicine. I'm teaching you. This is an intervention that you can do right in your office with your patients. So refined grains include which of the following? An endosperm, germ, bran, A and B, or B and C? So think about that for a moment. This is something I certainly was never taught in medical school, residency, or any of my training. Although I just showed you, despite not being taught about this, I just showed you the impact of not having enough whole grains has on mortality and cardiovascular disease. So why shouldn't we know the anatomy of a grain and be able to teach this to our patient? It really takes 30 seconds to give this information to your patient in the office. So let's look at the anatomy of a grain. A grain is composed of a bran, endosperm, and germ. And you can see that the majority of the vitamins and minerals, that whole grains are just packed with vitamins and minerals and fiber. The majority of it's located in the bran and in the germ. And the endosperm has mostly carbohydrates. There's a little bit of protein and there's some B vitamins, but all of the great antioxidants and vitamins and minerals are located in the bran and the germ. When you tell your patients to shop for whole grains, and we should be advising them to try to increase their whole grains in their diet. If you prepared the salad for today, then you have done that for yourself by adding the whole grains to your salad. Look for this. Look for the whole grain label right here on your screen. This certifies that what they're getting is actually a whole grain, and they're not being duped by ads that are trying to get them to buy bread that's been packed with a bunch of stuff that says made with lots of grains. So to make white flour, and that's the majority of what's consumed in the U.S., grain is milled, ground, and refined. And so when you refine a whole grain, you remove the brain and the germ, and all you're left with is the endosperm, basically the carbohydrate. So getting back to our question, refined grains include which of the following? The endosperm. That's it. Everything else goes away. Now let's turn our attention to dietary patterns. So this is Dr. Ansel Keys, who lived to be 100 years old, and he really started us thinking about how dietary patterns might influence health. And he did a study on men. In 1958, he looked at 11,000 men and followed them for over 25 years. And what he noted was that men from Greece and Italy, where fruits, vegetables, and grains and beans and fish were a major part of the diet, they lived longer and they had less heart disease. Now, during his time, he tried to parse out what were the components of the diet that made men live longer. And at that time, it was thought that it was really based on fat. And this led us to the low-fat craze of the 90s, right? Remember, everything was replaced, low-fat this, low-fat that. And the problem is when you take fat out and you manufacture something, you've got to put something else in there. And what that led to is a lot of processed foods that had to change the taste of foods to make it taste delicious because fats just taste good. So our food manufacturers started pumping sugar into our products as well as salt because they knew sodium is addictive, salt is addictive. It activates sugar is addictive. Both sodium and sugar activate the same centers in the brain as those in addiction to cocaine, etc. So smart marketing move on their part. They knew if they pump salt into a bag of potato chips, you can't just eat one. People will just keep eating them over and over again. So how about the Mediterranean diet? There's a lot of talk about that. And here's one of the early studies on the Mediterranean diet that didn't get a whole lot of press. It's a small study. It's here it is from the late 1990s. And this is a secondary prevention study that looked at 423 patients who were post-MI. They were hospitalized for their MI, and they were discharged on either a Mediterranean diet or a prudent diet. And on the Mediterranean diet, they were told to eat more fruits and vegetables and nuts, more whole grains and more fish. And they had to use olive oil and canola as their main source of fat. This was not a vegetarian diet, but they were told to really limit the amount of meat and animal products that they were eating. And then they compared this to people on a prudent diet in which there was a reduced intake of saturated fat and a reduced intake of cholesterol, but they were not guided about any of the other things like getting more vegetables, etc. This was a planned 5-year study, but it terminated at 4 years because of the significant improvement in the outcomes in the Mediterranean diet group. And what did that look like? So here is the Kaplan-Meier curves looking at cumulative survival without non-fatal MI over 5 years. And what you can see here is that there's a significant reduction in cardiovascular of non-fatal MI and survival in the patients that were in the Mediterranean diet group. And what you can see is that the impact actually starts very early on. At year 1, we start to see a significant impact here, which continues on over 5 years. And that gap continues to widen as time goes on. And you only needed 18 patients to treat in order to have benefit. Again, this is not a complicated diet, the Mediterranean diet, certainly not restrictive. And the ARR in this study was 0.28. 72% reduction in non-fatal MI and death after 5 years. Now let's turn our attention to one of this is actually the largest randomized diet trial done. And it's very hard to enroll patients in these dietary intervention trials, and I'll talk a little bit about that in a moment. But this one truly was a randomized trial where patients were randomized to a Mediterranean diet where they were actually given 1 liter of olive oil per week. It was sent to their home, and they were asked to take 4 tablespoons per day. And at minimum, 4 tablespoons per day at minimum. And then the second group was the Mediterranean diet, plus they were added nuts. So they were given 30 grams of mixed nuts. And then the control was simply a low-fat diet, prudent diet. And for those on the Mediterranean diet, there was no calorie restriction and there was no physical activity promoted. They just a dietary intervention. This is a pretty large study, 7,400 participants. So what did they find? For those patients that were on the Mediterranean diet, there was a 30% relative risk reduction in the primary endpoint of acute MI, stroke, or death from cardiovascular causes. Now, this was driven mainly by its reduction in stroke. And there's been a lot of controversy over this study and thoughts about, what was driving it, why was stroke more of a driver than other forms of cardiovascular disease. And it may be related to some of the animal products that they were using, or perhaps it was too much oil and nuts and the fats and stuff contained in those nuts. All right, so what diet is best? There are a lot of fad diets out there: keto, paleo, vegan, South Beach. Often makes it difficult to determine what the best diet is for our long-term health. And I just showed you what the public health data looks like, and we're going to simplify it here. We have the standard American diet, which I showed you on the first slide, and then we have the DASH diet, which you all are very familiar with. And the DASH diets and Mediterranean diets offer significantly more health benefits than the standard American diet. DASH, which stands for Dietary Approaches to Stop Hypertension. Both emphasize vegetables and fruits in the diet. They do allow for some meat, fish, and dairy consumption, although in much smaller portions than what Americans typically eat. The diets do have upper limits, such as limiting the amount of eggs per week or alcohol consumed. And they really exist on a spectrum toward our dietary North Star, which I will tell you is what in my practice we teach as the whole food plant-based diet, really based on all of the data that I just showed you. And I'll show you some additional data on refining that further. So what about meat? We just talked about the Mediterranean diet, allowing that in there. And what about animal protein and mortality? Why should we choose whole food plant-based, and what does that mean? Well, the definition of whole food plant-based it varies depending on what group. There's no central definition of whole food plant-based, and it can vary from just simply making everything whole food plant-based that could include animal proteins, or strictly what some consider as a vegan diet. So what's the evidence behind replacing or eliminating red meat or other animal products? So here's a prospective cohort study of greater than 130,000 participants from the Nurses' Health Study and health professional follow-up, showing that high animal protein intake was associated with higher mortality. There's tons of data on this, often smaller studies, all retrospective. But here's a meta-analysis of controlled trials of red meat consumption in comparison with various other diets on cardiovascular risk factors, which in summary showed that substituting red meat with high quality plant protein sources, but not with fish or low quality carbohydrates, leads to more favorable changes in blood lipids and lipoproteins. So quality is a really important word here, and I want you to keep that. If you remember one thing about this talk, just remember about quality of food, because quality is perhaps the most important thing to teach your patient about. Now, in terms of head-to-head studies on strict vegan versus the American Heart Association diet, and I'll show you some data on other vegetarian diets, let's clarify that the vegan diet has absolutely no animal proteins. And remember that the only source of dietary cholesterol is in animal products. So if your patients have, familial hyperlipidemia, or they're very young and, they really need to have long-term excellent control of their lipids, the only place that they're going to get dietary cholesterol is through animal products. And so this is a study that was done looking at the anti-inflammatory effects and other metabolic effects of a vegan diet versus the AHA recommended diet in cardiovascular disease. So remember, the AHA diet is already a very good diet. These are not patients eating standard American diet. Not a comparison on the standard American diet. I think the numbers would look tremendously different if we were looking at this compared to our standard American diet that's high in processed foods and red meat, etc. What you can see here is that the one thing that really came out of this trial was that the reduction in CRP was significantly greater in patients on the vegan diet than the AHA diet. And as you know, we don't really have targets for CRP other than modifying risk factors. So if your patients are really focused on numbers and they want to know, how do I get my CRP down? This is one way that they might be able to achieve that. Now let's just review briefly how this trial was conducted, and it highlights why it's so difficult to do diet trials. So when they looked at inclusion criteria, there were 691 participants that met initial inclusion criteria. This was an easy study. Patients were given food, they were told what to eat. So it wasn't like, random, and a lot of work was done for the patients to help them get the food that they needed. So of the 691 participants that met inclusion criteria, half of them did not want to change their diet. They just weren't interested, even though they knew that there could be some health benefits. So it really tells a good story there about why, imagine you can't get somebody enrolled in a trial, try to do that in your office, just implement change in your office. And some did not want to return for follow-up, and less didn't want to participate in research. So at the end of it all, there were 100 participants. 50 were on the vegan diet, and 50 were in the AHA recommended diet. But being on a plant-based diet isn't enough. An Oreo cookie is vegan, so one has to be mindful that if you're teaching your patients to eat plant-based, meaning eliminate animal products, or even if they're not eliminating animal products, just reducing them significantly will have major positive impact on their health outcomes. But they've got to do it right. It can't be, oh, I'm going to get this packaged food that says that it's organic and, whatever advertising dupe they're getting at the moment. We focus on whole food plant-based eating. In other words, if it needs a label, think twice about whether or not you should eat it. This is a study that looked at various types of plant-based diets that was published in JACS a couple of years ago. And what it found is that if you ate unhealthy plant foods, in other words, packaged foods, it was almost the same as eating animal foods, eating a regular, standard American diet. So in fact, it was worse. So, I'd much rather have my patients eat animal products and lots of whole foods than just eat a plant-based diet that's solely based on packaged and prepared foods. Why is it that red meat in particular is something that we do not advise our patients to eat or to eat very little of who have cardiovascular disease? Well, here's a little bit of insight into that. It may be that it all has to come down to our microbiome and how we metabolize the animal-based protein. And when people ingest certain nutrients like choline, which is abundant in red meat, egg yolks, and dairy products, and L-carnitine, which is also found in red meat, as well as some supplements, by the way, the gut bacteria that break it down produce a compound called trimethylamine, or TMA. The liver then converts TMA into the compound trimethyl N oxide, or TMAO, which has been correlated with development of cardiovascular disease, MI, and stroke. So, another reason to sort of replace those animal proteins with plant proteins do not produce TMAO. TMAO actually now it can be measured. It's a biomarker that can be measured through certain labs and through research protocols. But what about if you tell your patients to eliminate meat? This is the question they always ask. Well, where am I going to get my protein, doc? And here's just a nice chart sort of showing you the amount of protein in various plant-based foods versus animal protein. I mean, look at eggs in particular, because a lot of people get really fixated on, oh, I've got to have, protein. I'm going to throw a couple eggs in there or egg whites or whatever. Really, all they need is 1 cup of peas. They could add that to a smoothie in the morning instead of their egg, and they'll have all the other benefits of phytonutrients and fiber, et cetera. Animal products are really devoid in a lot of excellent phytonutrients. And Americans generally are over-proteinized. We are obsessed with protein, and in general, we get 2 to 3 times more than the recommended amount of protein. Now let's look at other health benefits of more plant-based dietary patterns. This is data from the Adventist Health Study, which in the Adventist population in Loma Linda, California, they really take health as a religion, and their dietary patterns are more close to vegan than any other population here in the U.S. So most of them are at least semi-vegetarians, if not full vegetarians, and they have the largest population of vegans. So it's a great population to study in terms of dietary patterns and health outcomes. But if you look here, I mean, just looking at odds ratio for hypertension based on dietary pattern, the closer your diet is to being purely plant-based without animal products, the less likely your risk of hypertension. Same thing goes for cholesterol. Again, dietary cholesterol, it only comes in animal products. And so you can see that the closer you are to being a pure plant-based, the better your cholesterol profiles. And then here's perhaps one of the somewhat controversial pieces of data just based on the number of patients that were studied that Dean Ornish looked at. And these are older studies that looked at not just dietary pattern, but also intensive lifestyle changes. So this was not a pure vegan diet that was promoted during this. These patients also were instructed to do aerobic exercise, manage their stress. They're instructed in smoking cessation, et cetera. In fact, he has a whole program that he has marketed that is, you can do it at your own institution, and Medicare will help pay for it, and they have a whole protocol that you can follow that follows the intensive lifestyle changes that he did during this study. But this is what it showed, that it suggests that you could have regression of coronary artery disease. They looked at patients' coronary angiogram. This is the 48 patients. So they did coronary angio pre and post intervention, and they actually measured plaque burden. And as you can see in the patients that were in the control arm, plaque burden increased in year 1 and after year 5, whereas they did see regression in patients in the intervention arm of the intensive lifestyle changes, which included a whole fat foods. It really wasn't a vegetarian diet. There's no animal products that are allowed in that diet. This is a classic picture that's shown by Dr. Estelstein, who's done the remainder of the work in this space, looking at pure whole food, plant-based eating. His diet is very, very low fat. You're not allowed oils or avocados, and it's all plant-based, very, very strict. This is an angiogram showing a coronary artery disease in this patient. November 1996, no intervention was made other than a dietary intervention, and here he is a few years later with, as you can see, not just the distal LAD, but improved perfusion throughout the entire myocardium. And this is what's been seen also in some of Dean Ornish's work, just in terms of burden of ischemia pre and post lifestyle interventions. So where are we now, and where do we need to be? This is your standard American diet, right? Remember the old commercials in the 90s? Where's the beef? The old Wendy's commercials. Well, now look at these pictures and tell me, where are the veggies? There's plenty of beef there. There's plenty of processed food. I mean, even just your spaghetti, there's no veggies in there. It's just processed spaghetti. There's no whole grains, nothing. So I challenge you to, sort of look at every meal that's on your plate and teach your patients and teach yourself that every time you pick up a fork, 3 times a day, or however many times you eat, you have an opportunity to do something good for your health and good for your body. And when you go to a restaurant now, even these days, you order a steak. Well, nobody's going to restaurants these days, but this is a pretty typical picture here where you see, you get this very big piece of meat and really small amounts of vegetables here, right? And so, really in healthful dietary patterns, the plate consists of mostly veggies and a small piece of meat. And even in Mediterranean diet patterns, prior to this century, really, meat was eaten once a month. It wasn't eaten, on a daily basis. You had it once a week or once a month. So, according to our current guidelines, the CDC recommends 1.5 cups of fruit and 2 to 3 cups of vegetables per day. But how many Americans do you think are actually following this? And as it turns out, only 1 in 10 Americans are actually adhering to the daily minimum of fruit and vegetables. What does the AHA-ACC tell us? Well, recommendations for nutrition and diet. Here is a class 1 recommendation. A diet emphasizing intake of vegetables, fruits, legumes, nuts, whole grains, and fish is recommended to decrease ASCVD risk factors. So, pretty broad definition there. Now let's talk about specific foods that can help our patients, specifically if they have coronary heart disease. This study looked at the effect of fruit and vegetable intake on risk for coronary disease, and it showed that for every 1/2 cup of dark green leafy vegetables, there's a 23% risk reduction in coronary heart disease. So just telling your patients have a half a cup of dark leafy green vegetables is an intervention. How about dietary nitrates? So here was a study looking at patients with hypertension that were given beet juice, 1 cup of beetroot juice a day for 4 weeks. And there was a mean reduction in blood pressure of 8 millimeters of mercury over 2 millimeters of mercury. And when you look at nitrate-rich foods like beets and other green leafy vegetables, what happens is the bacteria in our saliva converts the nitrates to nitrites, which may be, what helps with some of the positive cardiovascular benefits that we see when people eat these foods. Interestingly, when people use antiseptic mouthwash for a week, the conversion is then inhibited because you've changed the microbiome in your saliva. How about blueberries? So 1 cup of blueberries per day over 6 months in this study led to improved endothelial function, attenuated cyclic GMP concentrations, and increased HDL. So diet does work. And I'm going to share just a few cases that I have some patients that I've been working on, this novel cardiac intervention known as food. So I will start with, in the interest of time, I've kept these cases brief, but I do want to just highlight a few changes that these patients made. This is a 46-year-old gentleman with no medical history, very active, BMI of 24, active in his kids' lives, playing baseball all the time, running, etc., and no history of hypertension or any other, who presented with chest pain and had a positive stress test and ultimately was noted to have multi-vessel coronary disease and underwent bypass surgery in September of 2019. So on the right of the screen, you can see this is his baseline in September, and you can see his LDL at the time was 199, and his non-HDL cholesterol was 228. At the time of his hospitalization, he was started on atorvastatin 80 and also Vascepa, and we talked about diet, but he was, ready to institute some changes, but wasn't quite sold on stringent changes. And he reported his diet as being pretty good overall, but he kind of eats what he wants when he wants as well. And here he is, just a few months later, on this quote unquote plant forward diet. And at that time, and the atorvastatin 80. So you see a good reduction in his LDL with that atorvastatin 80. And he again was started on Vascepa. But at that time, we talked a lot about that his LDL goal, really, particularly given his age, wanting that LDL goal to be as low as possible. And at that time, he wasn't ready to do add-on therapies or med therapies, but he was committed to dietary changes. And he decided to follow a strict plant-based diet, meaning no animal products, and he minimized oils, and for a time had no oils at all. But really this, sort of became a vegan diet. And look at the dramatic reduction we get just from that intervention over 2 months. So the LDL now drops to 65. We do see when patients adopt vegan or more plant-based diets, you do see reduction in HDL as well. Probably owing to reduction in some of the more harmful particles, HDL particles. And you see his triglycerides went down dramatically as well. And again, was non-diabetic. His A1C at presentation was 5.2. So great success story, and this patient continues on. I'll be following up with him in a few weeks. So here's another patient. Just when you think your interventions won't work, you'll be surprised. This is this case actually is a patient who was a 41-year-old vegetarian with a history of hyperlipidemia, but not on any meds at the time, had some chest pain in December and was found to have a occluded RCA and underwent PCI. At the time, in December of 2019 was when he had his event. And I added on here January 2019, just for reference. At that year prior, his LDL was 140. Cleaned up his diet a little bit, was doing a vegetarian diet, but still having milk products and cheese and processed foods. And you can see at the time his LDL-C was 115. Now he was started on atorvastatin, and from there you could see he had a dramatic reduction in his LDL. So this again, some of this is the atorvastatin, and which was later switched actually to Crestor 40. So he was on the atorvastatin for a couple weeks, and then it was switched over to Crestor. But he also adhered to a very strict plant-based diet, cleaned up all the other animal products and the processed foods that he was eating, and he was able to achieve an LDL-C of 30. But so think about it. I mean, this was 140 was his baseline, but when he was still having a loose impact on his diet, and now just by combining Crestor plus a plant-based diet, his LDL-C he's achieved tremendously low level. Incidentally, this patient was not interested in losing weight. He wasn't trying to lose weight. He had, BMI of 24 to begin with, 23, 24 to begin with. But when he changed his diet, he was eating more, and he actually had a pretty dramatic reduction in his weight. So he started at 151 and he lost 10 pounds. So here's the patient who came to me, who I thought, sort of was one of those people that wasn't interested in lifestyle interventions. I didn't really talk to him about diet a whole lot because I was so worried about these numbers that he had, and he was diabetic. And at the time weighing 217 pounds, the BMI of 30. And just as he was leaving my office, he said, Doc, is there anything else you could offer me? Like, is there anything I can do with my diet to help with my cholesterol? And I said, sure. Do you have an hour? And we talked all about plant-based eating, and he actually became a strict whole food plant-based dieter and was completely vegan. He did that for several months. And the most dramatic thing that happened in this case was that he dropped his A1C from 7.9 to 6.7, and his insulin dose went slowly over time because we were obviously in very close contact during this 5 months. His insulin dose kept going down and down and down and down, and he was able to achieve this A1C of 6.7, and his insulin was down to 35 units. His triglycerides are sort of all over the place. He does have unknown hypertriglyceridemia for a number of years, and he occasionally doesn't take his fenofibrate. But again, dramatic reduction in the LDL. This is not a statin effect. This is just simply him switching to a whole food plant-based diet. Fenofibrate is on and off on this gentleman. And again, weight loss. He wasn't, dieting, but he did have a dramatic reduction in his weight from BMI of nearly 30 down to 29. So we got him from the obese category to the overweight category. And we are almost to the end here. So I'll just show this quickly. This is a gentleman with AFib, hypertension, and obesity, and had new onset AFib and really wanted to learn about lifestyle interventions for managing AFib. And he was someone who went on a whole food plant-based diet, but also kept lean poultry and fish in his diet, and was started on Crestor early on. So what you're seeing here from September 2019 to September 2020 was simply dietary interventions, and he was also known to be a pre-diabetic. So on the whole food, lean poultry and fish diet, you see had a pretty dramatic reduction in his weight. He lost over several months. He was starting out in the high 230s and or almost 230, and he lost over 20 pounds. So these diets work not only improving your metabolic profile, they can also help to reduce weight. So we have to not only teach our patients about what to eat, but how to do it. And that's sort of how we started this talk, is by me showing you how to assemble a salad that has whole grains and all of those really heart healthy, beneficial foods in it. And that's one thing I would encourage you to do. This is I actually have a teaching kitchen in my office, and here we are doing a hands-on teaching class where we gather everyone together and we show them how to prepare vegetable-based foods. So in summary, dietary factors have a significant correlation with the development of cardiovascular disease beyond the traditional viewpoint of cholesterol. And there are specific food groups that are associated with a decreased incidence of cardiovascular disease, including whole grains, green leafy vegetables, and berries. And a healthy dietary pattern is really focused on whole foods. Again, think quality, 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 quality from a variety of plant-based sources. And your office interventions are simple and truly can be impactful. Small dietary changes can have a big impact. And so in summary, keep this in mind. As Michael Pollan says in his book, eat food, not too much, and mostly plants. The simplest advice that you can give to your patients. Here are some resources if you want to learn more. These are a wealth of information in terms of plant-based eating and conferences on healthy eating. And you can also follow me on Twitter or Instagram, as you see there. And at that, we will adjourn and take questions. And I'll leave you with a quote from the good Thomas Edison, who said that the doctor of the future will no longer treat the human frame with drugs, but rather will cure and prevent disease with nutrition. Thank you.